namely a patient who's got renal failure, renal insufficiency, right? So for example, I don't know if it's in your notes, it's in my bigger book, but I had a patient when I was doing hospital medicine, family medicine in Austin, fully asymptomatic. He just came in for a routine health check, and she had a serum potassium of 8.6, right? 8.6 is the value, which is about 6.5 or so. So that's a legitimate concern, right? So you don't want to do the right thing, namely a fruit and vegetable whole food diet, in the wrong patient, in this case renal insufficiency, right? So that's why I put the I here for interactions with drugs and diseases. Does that make sense? What would be an example of some drug interactions with the conditions and the treatments that we're talking about right now? Hydrochlorothiazide, I think, is a kind of a yellow flag when mixed with vitamin D. And I said yellow flag, not red flag. I don't think it's an absolute contraindication. I just think you have to be aware of the fact that you could induce hypercalcemia if you mix those two things together. I've seen it once. Mark Houston, who sees a lot more cardio patients than I ever will, said he's never seen it. And that's fine, but I'm just saying, let's just be aware of the possibility. If a patient's on, potassium-sparing diuretics and we put them on a high potassium diet, what would be the expected outcome that we want to be aware of? Hyperkalemia, right? So you want to keep an eye on their potassium levels if that's the situation. Obviously some other drug interactions. You don't want to put patients on a high fruit and vegetable diet that has a lot of vitamin K if they're on Coumadin, warfarin, right? I mean, basic stuff like that. So interactions with diseases and drugs. R stands for referral and also return visit. So I'm sure most of you in clinical practice know that by now, but for some patients, and especially the students I teach, we have to remind ourselves that, hey, when's this patient coming back, right? And do we need to refer them out? For example, like when I work with autoimmune patients, I'm happy to work with them, but I also want them to have a rheumatologist on board, right, in case they need to be immune suppressed if something starts going wrong. What would that be? Transverse myelitis. If a patient starts developing transverse myelitis, the outcome's not going to be very favorable, but I'd like to at least be able to make a quick referral back to a doctor who's already familiar with the case. T stands for treatment plan. Sign it, date it, keep it in the chart, preferably give a patient the copy as well, right? And that might sound simple, but when I do malpractice defense for doctors, sometimes I review their charts and they haven't signed their chart, they haven't dated it, they don't have a diagnosis, they don't have a treatment plan, they don't have a follow-up. That's why I developed this, right? This is like malpractice risk mitigation. So we go from DIRT, and then you all know the SOAP. I realize I'm writing very small, that's because I want to save my space for other things. Subjective, objective assessment and plan. That's what we all learn in medical school. So it's kind of cool. Look how this plays out. We go from DIRT to SOAP, and then what's next? Right? Right. So you could do FIND-SET for toxins or FIND-SEX for xenobiotics. So our F, which we already went through, is obviously food. And then the way that I think about this visually is, okay, well, what are we talking about when we're talking about food? We're talking about the 5-part supplemented Paleo-Mediterranean diet. So I put 5 SPD, 5-part supplemented Paleo-Mediterranean diet. So what's paleo? Fruits, vegetables, nuts, seeds, and berries. What's the supplementation? Multivitamin and multimineral, high potency, broad spectrum. Enough vitamin D to do the job, right? Not just to meet guidelines, because guidelines are designed to keep people deficient, apparently. Combination fatty acids and probiotics, right? So those are the 5 components to this plan. And then we go, and then allergy elimination, and preferably organic. And then we go to I. So what's the I stand for? Infections, but we're really talking about dysbiosis, right? So these are kind of like chronic smoldering colonizations or infections. They're not true infections, but just colonization. So I'll put infection, dysbiosis. Okay? So we talked about different locations where that can occur, right? Gastrointestinal tract, sinuses, skin, genitourinary tract, those are the major ones, right? Environmental, etc. But from a clinical implementation standpoint, what do we do about this? What do we do about dysbiosis? There are 3 things that I reviewed, 3 general categories. One is, we're talking about microbes, we're talking about an adverse response to microbes. We're not just talking about microbes. So we could kill off the microbes. If there are no microbes, there can be no dysbiosis, right? Because dysbiosis, by my definition, is an adverse response to microbes. Well, if you've got no microbes, you've got no adverse response to something that doesn't exist. So we could use, I'll just put ABX as an abbreviation for antibiotic therapy. What else could we do? We could ask, well, why did this patient have these microbes to begin with? Maybe they're immune suppressed due to dietary deficiency. So we could use what we generally call, for example, in naturopathic medicine, we call it immune support. I call it immunorestoration, nutritional immunorestoration. So I'm just going to say immune nutrition. And then what else could we do? We could help the person become more tolerant of the inflammatory bacteria that they're harboring, the inflammatory response that they're manifesting, right? So then we get into nutritional immunomodulation, and I'm going to call that number 3 because it is number 3. This is number 1, this is number 2, and number 3 is nutritional immunomodulation. And then how did I encourage you to remember that? So we went through a lot of slides, and at the last minute I kind of put it together with that plaid FIGS acronym, right? So P stands for what? Probiotics. L stands for lipoic acid. 1,200 milligrams a day is your goal, so you want to do 400 3 times a day or 300 4 times a day. You can do whatever you want. You just want to get to 1,200 milligrams per day, lipoic acid. A stands for what? Vitamin A. So I typically load them and then put them on a maintenance dose, as I already described. What's I stand for? Getting rid of the dysbiosis, because dysbiosis can cause this immune imbalance, or getting rid of excess inflammation. So the I we're going to look at twice because it exists in the acronym twice. It could be infection or inflammation. We want to address that. What's D stand for?
Vitamin D.
Vitamin D. What do we want to do in adults? 4,000 international units. But most importantly, we want to optimize their serum levels, as we talked about before. Then we have another I, which, oh, sorry, no, we don't. We have a G. It's kind of like I'm like Vanna White up here. So what's the G stand for?
F first.
Yeah, I'm trying to do this thing sideways. Sorry. Let's do F. What's the F stand for? Fatty acids, right? We're talking about the same fatty acids that we used up here, just like we're talking about the same vitamin D that we used up here. So you're starting to see some overlap, right? Which is really important. Because what you're going to see is we see some redundancy here. We see a lot of physiologic, synergistic redundancy with nutrients in a way that we don't see with drugs, right? No, nutrients help the body work better. Most drugs block the way the body works, right? And that's real. And I actually read that. I mean, it's kind of obvious. If you look at most drugs, they block things, right? Calcium channel blockers, angiotensin II receptor inhibitors, and ACE inhibitors. Statin drugs are all HMG-CoA reductase inhibitors. That's how drugs work. Most of the time, they're receptor blockers or they're enzyme poisons, basically. And not to say they don't have beneficial effects here and there, but let's make things work better instead of blocking a system that's already out of balance. Okay, so back to this G, which then turned into an F. I'm writing sideways, over caffeinated. What's the F stand for, and what are the mechanisms here? So we're talking about omega-3 fatty acids. Mostly we're talking about EPA and DHA from fish oil, but I think you get some benefit from ALA too. So some of the anti-inflammatory benefits from omega-3, alpha-linolenic acid from flax oil, are not due to its conversion to EPA and DHA, right? So fish oil alone is not as good, in my opinion, as fish oil with ALA, even though, kind of a simplistic